इंटास फार्मा विश्व में पहली ऐसी कंपनी है जो हाइपर इम्यूनोग्लोबुलिन के डोजेज के जरिए कोविड के पेशेंट्स को ट्रीट करने की पद्धति डेवलप कर रही है। ये प्लाज्मा थेरेपी का एक अल्टरनेटिव के तौर पे इसे डेवलप किया जा रहा है और प्लाज्मा थेरेपी से बताया जा रहा है कि ये कई गुना इफेक्टिव है और कई गुना प्योर भी है। और अब तक इसके लेबोरेटरी टेस्ट जितने भी हुए हैं उसके काफ़ी सटीक परिणाम मिले हैं, जिसके बाद अब DCGI द्वारा इसे ह्यूमन ट्रायल्स की परमिशन दी गई है कंपनी को। और ह्यूमन ट्रायल्स के बाद ये दवा जो है ये 4 महीने में बाज़ार में लॉन्च कर दी जाएगी।
प्लाज्मा थेरेपी जो आज हम दे पा रहे हैं, एक तो वो काफ़ी संसाधन उसके लिए लगते हैं, क्योंकि प्लाज्मा फ्रैक्शनेशन की जो फैसिलिटी है वो हर सेंटर पे अवेलेबल नहीं हो पाती है और प्लाज्मा के साथ डील करने के एक अपने चैलेंजेस हैं। उसके सामने अगर हम देखें तो जो हमारी हाइपर इम्यून ग्लोबुलिन ड्रग है वो एक निश्चित मात्रा में, एश्योर्ड मात्रा में एंटीबॉडीज़ मरीज को दे सकते हैं। इसकी हैंडलिंग काफ़ी इजी है। उसके सामने जो वॉल्यूम हमें देना पड़ता है, प्लाज्मा में जनरली हम 200 से 400 ml तक वॉल्यूम पेशेंट को देना पड़ता है, उसके सामने इस दवाई की जो वॉल्यूम हमें देनी पड़ेगी वो 30 से 60 ml तक की वॉल्यूम में वो काम हो जाएगा। और उसके जो बॉडी के ऊपर जो एक्स्ट्रा वॉल्यूम का जो लोड है वो वॉल्यूम का लोड भी इससे कम होगा। तो हम निश्चित मात्रा में, सटीक हम मात्रा में उस दवाई को दे सकते हैं। हैंडलिंग इसकी काफ़ी ईजी है और ये देश के किसी भी कोने पे ये दवाई पहुंचाई जा सकती है। जहां पर प्लाज्मा थेरेपी भी पॉसिबल नहीं है वहां पर भी हम इस थेरेपी को पहुंचा सकते हैं और लोगों को वो फ़ायदा पहुंच सकता है। अभी तक के जो हमारे रिज़ल्ट्स हैं वो काफ़ी अच्छे रिज़ल्ट्स मिले हैं। इसके लिए न केवल हमने अपने प्रोडक्ट्स को बना के उसको स्टेबल करके और उसको एक क्वालिटी को इंश्योर किया है, साथ के साथ हमने जो एक बहुत ज़रूरी चीज़ होती है कि ह्यूमन में ये ट्रायल करने के पहले आपको ये सिद्ध करना चाहिए कि ये वायरस के ऊपर प्रभावी है। इसके लिए हमने इन विट्रो टेस्ट किए हैं विद लाइव वायरस कल्चर, जो कि एक गोल्ड स्टैंडर्ड माना जाता है। उसको हमने गवर्नमेंट की अप्रूव्ड संस्था के थ्रू उसका हमने टेस्ट किया है और उनकी इंडिपेंडेंट रिपोर्ट है और उन्होंने हमारे वायरस न्यूट्रलाइजेशन कैपेबिलिटी ऑफ दिस प्रोडक्ट को एश्योर्ड किया है। तो उस वजह से हम काफ़ी आशावादी हैं कि ह्यूमन ट्रायल के अंदर में इसका काफ़ी अच्छा रिजल्ट मिलने की संभावना है। हमें लगता है कि हमारा जो अभी तक का इसके ऊपर डेवलपमेंट है वो काफ़ी आगे की स्टेजेस में है और मुझे लगता है कि भारत वो पहला ऐसा देश होगा जो इस तरह की दवाई को अपने मरीजों को देने के लिए सक्षम हो पाएगा। और हमारी उम्मीद ये है कि अगले 4 से 5 महीने के अंदर में हम इसके रिजल्ट्स को सरकार के सामने प्रस्तुत कर पाएंगे और उस की तरह से फिर ये हमारे मरीजों को देने के लिए उपलब्ध हो पाएगी।
सबसे खास बात यह है कि इसे इम्प्लीमेंट करने के लिए पेशेंट के ब्लड ग्रुप मैच करने की भी ज़रूरत नहीं है और आगे चल करके इसे कोविड से बचाव के तौर पर भी उपयोग किया जा सकता है, वो भी इसमें पोटेंशियल है। और सबसे खास बात यह है कि जब तक कोविड के इलाज के लिए कोई वैक्सीन डेवलप हो पाए उस दौरान एक इंटरमीडिएट ट्रीटमेंट के तौर पे इसे काफ़ी इफ़ेक्टिव उपाय माना जा रहा है। कंपनी इसे अपने CSR इनिशिएटिव्स के तहत डेवलप कर रही है और सरकार को फ्री में ये ड्रग्स दिए जाएंगे जिसको बाद में सरकार पेशेंट्स तक पहुंचाएगी। कैमरामैन अमित राठौड़ के साथ निर्णय कपूर, इंडिया TV, अहमदाबाद। इंटास फार्मा विश्व में पहली ऐसी कंपनी है जो हाइपर इम्यूनोग्लोबुलिन के डोजेज के जरिए कोविड के पेशेंट्स को ट्रीट करने की पद्धति डेवलप कर रही है। ये प्लाज्मा थेरेपी का एक अल्टरनेटिव के तौर पे इसे डेवलप किया जा रहा है और प्लाज्मा थेरेपी से बताया जा रहा है कि ये कई गुना इफेक्टिव है और कई गुना प्योर भी है। और अब तक इसके लेबोरेटरी टेस्ट जितने भी हुए हैं उसके काफ़ी सटीक परिणाम मिले हैं, जिसके बाद अब DCGI द्वारा इसे ह्यूमन ट्रायल्स की परमिशन दी गई है कंपनी को। और ह्यूमन ट्रायल्स के बाद ये दवा जो है ये 4 महीने में बाज़ार में लॉन्च कर दी जाएगी।
प्लाज्मा थेरेपी जो आज हम दे पा रहे हैं, एक तो वो काफ़ी संसाधन उसके लिए लगते हैं, क्योंकि प्लाज्मा फ्रैक्शनेशन की जो फैसिलिटी है वो हर सेंटर पे अवेलेबल नहीं हो पाती है, और प्लाज्मा के साथ डील करने के एक अपने चैलेंजेस हैं। उसके सामने अगर हम देखें तो जो हमारी हाइपर इम्यून ग्लोबुलिन ड्रग है वो एक निश्चित मात्रा में, एश्योर्ड मात्रा में एंटीबॉडीज़ मरीज को दे सकते हैं। इसकी हैंडलिंग काफ़ी इजी है। उसके सामने जो वॉल्यूम हमें देना पड़ता है, प्लाज्मा में जनरली हम 200 से 400 ml तक वॉल्यूम पेशेंट को देना पड़ता है, उसके सामने इस दवाई की जो वॉल्यूम हमें देनी पड़ेगी वो 30 से 60 ml तक की वॉल्यूम में वो काम हो जाएगा। और उसके जो बॉडी के ऊपर जो एक्स्ट्रा वॉल्यूम का जो लोड है वो वॉल्यूम का लोड भी इससे कम होगा। तो हम निश्चित मात्रा में, सटीक हम मात्रा में उस दवाई को दे सकते हैं। हैंडलिंग इसकी काफ़ी ईजी है, और ये देश के किसी भी कोने पे ये दवाई पहुंचाई जा सकती है। जहां पर प्लाज्मा थेरेपी भी पॉसिबल नहीं है, वहां पर भी हम इस थेरेपी को पहुंचा सकते हैं और लोगों को वो फ़ायदा पहुंच सकता है। अभी तक के जो हमारे रिज़ल्ट्स हैं वो काफ़ी अच्छे रिज़ल्ट्स मिले हैं। इसके लिए न केवल हमने अपने प्रोडक्ट्स को बना के उसको स्टेबल करके और उसको एक क्वालिटी को इंश्योर किया है, साथ के साथ हमने जो एक बहुत ज़रूरी चीज़ होती है कि ह्यूमन में ये ट्रायल करने के पहले आपको ये सिद्ध करना चाहिए कि ये वायरस के ऊपर प्रभावी है। इसके लिए हमने इन विट्रो टेस्ट किए हैं विद लाइव वायरस कल्चर, जो कि एक गोल्ड स्टैंडर्ड माना जाता है। उसको हमने गवर्नमेंट की अप्रूव्ड संस्था के थ्रू उसका हमने टेस्ट किया है, और उनकी इंडिपेंडेंट रिपोर्ट है, और उन्होंने हमारे वायरस न्यूट्रलाइजेशन कैपेबिलिटी ऑफ दिस प्रोडक्ट को एश्योर्ड किया है। तो उस वजह से हम काफ़ी आशावादी हैं कि ह्यूमन ट्रायल
ये ड्रग्स दिए जाएंगे जिसको बाद में सरकार पेशेंट्स तक पहुंचाएगी। कैमरामैन अमित राठौड़ के साथ निर्णय कपूर, इंडिया टीवी, अहमदाबाद।
Good evening to you all. My name is Amit Arora, and I extend a very warm welcome to all the delegates who have joined in today for this third edition of Practice Pulse in Hypertension. As you know, hypertension is a very big health problem in India, and more than 20 crore Indians suffer from hypertension. 9 out of 10 hypertensives do not achieve their BP goal of less than 140/90. To address these issues, we have initiated Practice Pulse in Hypertension under the guidance of Professor J.C. Mohan. Professor J.C. Mohan is a very well-known figure in the field of cardiology. He is chairman of Jaipur Golden Hospital in New Delhi, and he has many accolades to his credit, and he has won many awards in his illustrious career. So to take the meeting forward, I would invite Professor J.C. Mohan to the stage to take the meeting forward. Professor J.C. Mohan, sir.
Thank you, Amit, and good evening, ladies and gentlemen. Special welcome to Dr. Tripathi, Dr. Mishra, Dr. Mehrotra, and Dr. Silaja, who will be joining in a while. As Amit rightly said, that hypertension is a major public health problem and is currently affecting nearly 1/3 of the adult mankind, and is responsible for about 13% of the entire global mortality. And at least in low and middle income countries like India, the control is abysmal, despite drugs being quite inexpensive. There are many issues with regard to hypertension as a public health problem. We have started this web series 2 months back, and we discussed some of the interesting topics. So in this webinar, actually, we tend to actually have two different components. One, of course, a didactic lecture on a topical issue, and another is, of course, interesting, unusual case presentations where hypertension management is a challenge. In the previous two webinars, we discussed about resistant hypertension and chronotherapy of hypertension. And in this particular webinar, we would be discussing about secondary hypertension. Is it needle in haystack? The reason is we normally don't think of secondary hypertension when we are treating because over 90% of our hypertension patients have what we call as primary or essential, which itself is a misnomer. But there are reasons, and of course there are good reasons to suspect many of these patients' hypertension could have secondary causes. To take us through the entire gamut of secondary hypertension, how to suspect, how to diagnose, how to manage secondary hypertension, we have an eminent personality in Dr. K.K. Tripathi from Varanasi. He is the professor and head of medicine of Banaras Hindu University and Institute of Medical Sciences of Banaras Hindu University, and probably one of the best guys ever heard to speak on hypertension. And it is my proud privilege to have known him and also listened to him on several occasions. Professor Tripathi is going to take us through this. He is actually a nephrologist by training. And the interesting part is that a lot of us believe that hypertension originates in kidney, and it's not an issue which is, it becomes secondarily a cardiovascular issue. Essentially, it is a nephrogenic problem. And of course, secondary hypertension can also be nephrogenic in 5–10% people. To take us through the entire gamut of secondary hypertension, to talk about all the possible causes, diagnostic algorithm, therapeutic algorithm, we have Professor Tripathi. So ladies and gentlemen, I present to you Professor Tripathi to take us through secondary hypertension as our third webinar main topic. Professor Tripathi, sir.
Thank you, sir. Thank you, Dr. Mohan. Thank you, Praveer. Thank you, Amit, for giving this opportunity. And can I share my slide now?
Yes, sir. Please go ahead.
And as Dr. Mohan said, that hypertension, and I'm taking the road journey from his last statement, that it started with the nephrologist. Though William Harvey discussed about the physiology of the heart, lot of physics, because he had a background of physics and mathematics. Somewhere in the 17th century, William Harvey was a British cardiologist, physiologist, physician. But then concept of hypertension as a disease was mooted by Richard Wright. And there were three friends at the Guy's Hospital. Those of us who have ever gone to London must have visited Guy's Hospital. This is like going to the temple of Kashi Vishwanath when you come to Varanasi. And the Guy's Hospital had three friends. And these three friends were Richard Wright, Hodgkin, and Edison. And all started their primary career as a pathologist. So my teacher used to talk to us those days when we were in the undergraduate, that the pathology is the grammar of medicine. So they started basic all pathological process looking into and then translating into clinical medicine. So Richard Wright has a credit to correlate between the three autopsy findings together on one patient who had a chronic contracted kidney, left ventricular hypertrophy, and when he looked at to the blood vessels, they were atherosclerotic vessel, and then the recurrent proteinuria. And from there it started that probably the hypertension as a disease starts into the kidney. So it's my privilege that I have lot of these three learned people. Dr. Mohan is excellent cardiologist, and also I have heard him many times too. And we are going to start to you as the one of the part of hypertension which belongs to nephrologist and endocrinologist. And we have two on the panel, these two scientists. As you said, this is from the Hypertension Awareness Treatment and Control Reference Program in our country, and the graph shows that the awareness is close to 40 to 50. Friends, and luckily two friends are related to the hypertension, and Addison, who described Addison's disease letter, and the Bright himself, who described the Bright disease. And this is the epidemiology what Dr. Mohan was also talking, that in spite of the fact that close to 50% people are aware of hypertension, 32% of the people only on the treatment. As he said, it's very cheap to have a treatment, but still we do not have target population for the treatment, and 17% hardly have been there who have controlled blood pressure with all whatever medicine. The prevalence goes as we have the Jaipur study by Dr. Gupta, the epidemiology have shown time and again that the all urban had a higher population. It is the migrated people living in the slum as well as the rural both. And the prevalence close to 30.7%. Diabetes prevalence is about 10. And we are now getting 13.7% hypertension running ahead of diabetes. And some of us would be having both insulin resistance, a lot of component with obesity, insulin resistance, and diabetes. Why secondary hypertension? Dr. Mohan already said that this is one area, though the hardly 5% to 8% people of the whole lot would have having secondary hypertension. But these are the patients who are underdiagnosed. They require more medicine. They get lot of complication. But if they're detected early, this is one hypertension which could be cured easily. The causes start from the kidney as such and renal artery stenosis, though renal hypertension itself is a vascular phenomena. But then we had the famous physiologist Guyton. The Guyton started this concept, gold blood and Guyton together. Guyton started the concept of the exaggerated natriuresis, pressure natriuresis, which is an important component for the secondary hypertension. And the gold blood get the concept of kidney 1, kidney 2 hypertension, creating experimental renal artery stenosis and hypertension. So we start with the renal causes like renal artery stenosis. Clinically, we all were examined as an undergraduate that did we listen to Brooey in the flanks to exclude secondary hypertension like renal artery stenosis, worsening of serum creatinine as the time advances, and then renal parenchymal diseases mostly remain asymptomatic to begin with, and then primary aldosteronism like Conn's syndrome, FEO, Cushing, hypothyroidism, coarctation of the aorta, and obstructive sleep apnea, which have recently been added in last 1 decade. We have become aware of these OSA, and then drug induced. And we have a specific now investigation which we are not before. So we are much wiser now than the previous time, and we'll come to first the strategies how to guess that these patients could be. Like 5 to 10%, and few diseases, they are recognized by their clinical symptom rather than the hypertension, like obstructive sleep apnea, renal diseases, coarctation of aorta, Cushing syndrome. Few diseases would have accelerated hypertension, have a resistant hypertension like FIOS. So what can I do in my practice? How do we approach and how do we try to screen these patients? As I said in the beginning, history taking is quite important. And the moment we know that this patient is hypertensive for a long time and blood pressure is more than 140/90 with a sphygmometer or whatever non-invasive device we are taking, and then when we have examined, found asymmetry, then could be coarctation. So it could start very simple. Asymmetry of the pulses and the difference between the femoral and the brachial or the radial, what we take. All our teacher and his examination would insist upon, which we hardly do now, to touch the feet of the patient, look at the dorsalis pedis, look at the popliteal, look at the femoral, look at the carotid, look at the radial, and coarctation of aorta could be diagnosed. Like other condition, diabetes, hyperlipidemia, family history. So history taking is as important as it used to be 100 years before, today, maybe 100 years after also. Do we really put some time on history taking? Probably not. So it is an important component when we make our suspect the secondary hypertension. Patient is young, less than 30 years of age. Renal and coarctation of the aorta has to be thought. Then symptom and signs suggesting secondary causes. Indication of severe hypertension, resistant hypertension, and peeping into the fundus, one of the important part that in spite of acceleration of the hypertension, often these patients, the fundus remain, with such a hypertension, fundus remains quite normal. Acute worsening of hypertension patient with quite stable and suddenly there's upsurge in the blood pressure. So we'll talk few individual condition and approach. The most important is why I said so, because it could be a drug induced as well. I talked in the list, primary aldosteronism. Though it was thought to be rare, but out of the whole lot, could be close to 13% of the diabetic patient who present as a resistant hypertension. Meaning by 3 drugs and one of the diuretic, we are not able to get the result. This is well recognized now, and patient with having hypokalemia could be one of the strong suspicion, and this patient could have close to 30%. CMC Velour has a very good series, and those of some time we have heard there are some very good publication from Velour, and they have showed it. It was there in our API about 3 months back. So how about primary aldosteronism? Number 1, hypokalemia is one of the issue, and these hypokalemia and medication needs to start looking at the laboratory test. Lot of drugs and they would not interfere. And what are the indication on which we would consider? Number 1, these patients are lean and thin, and the dry patient, in spite of hypertension, they do not develop pedal edema. Blood pressure could be high, 150 to 100, difficult to control. With 3 medicine, 140/100, and one of them should be the diuretic. Hypertension associated with hypokalemia could be diuretic induced or spontaneous, and these are because the range is very narrow. These patients at a time become very difficult and could develop cardiac arrhythmias. Prior to test, stop spironolactone, eplerenone, or amiloride for at least 6 weeks and correct potassium to within normal range. And this is the test. We measure the aldosterone, renin, and potassium. And usually, most of the time now, they are done into a tertiary care institution or a hypertension clinic. They are not done routinely. Aldosterone should be more than 460 picromole. Again, it's a more research tool, but you can get it done. You can ask for some of the laboratories like SRL lab and Dr. Lal Path lab. They do it on your order. What is the key point? That unilateral primary aldosteronism is a common cause of the secondary hypertension, but this is potentially curable. and you can do a surgery and you can treat it. And the PET CT offers a rapid, non-invasive diagnosis, which we never used before, and we never had those privilege. So this is easy to do now, and there are management options. One can go for surgery, do the unilateral adenectomy, or we can use MRA, spironolactone or epinephrine for the adrenal hyperplasia who are not suitable for surgery. Then obesity and the metabolic syndrome, which is obstructive sleep apnea. These patients have insulin resistance, and then also they have the resistance to antihypertensive drugs. This is quite clinically now obvious, and these are the patients who have got obese, somnolence, nocturnal gasping or choking, and they are the non-dipping hypertensive patient when you do ambulatory blood pressure monitoring. And then these are the patients who would be responding to CPAP. And the good part is that you give them 3 to 4 month treatment and they all revert back. They revert back their obesity, the insulin resistance, as well as the blood pressure. Many patients remain undiagnosed, though they snore, and people think that snoring is a good sign, healthy sign. It's a bad. High index of clinical suspicion is needed, and the symptoms, loud snoring, daytime somnolence, is a very high risk, and patient could develop sometimes in cardiac arrhythmias. This is the list, of the endocrine causes. Hypothyroid as well as the hyperthyroid both can present to secondary hypertension. And the good part, you treat them, it controls very easily, gets controlled very easily. And we know the clinical sign, which is very easy to diagnose: dry skin intolerance, constipation for the hyper, tremor, moist skin, heat intolerance, nervousness, anxiety, weight loss, diarrhea. Hypercalcemia with primary hyperparathyroidism, very rare, but we do see, and I think in last about 30-40 years of the clinical, we must have seen with our endocrine department help about 5-10 patients. This evening, right now, before, young psychiatrist doctor, she came to me just about half an hour before, and she had hyperparathyroidism with a lot of other disorders, calcium, seizure disorder, then congenital adrenal hypoplasia, what we call Conn's syndrome, but then it differs because there could be 11 beta hydroxylation or 11 desoxycortisone, 17 alpha. These are the different level of the synthesis of the cortisone in the adrenal medulla, and according to patient presents with hypertension, hypokalemia, virilization. Again, they are quite rare. Maybe very able clinicians see 1 or 2 in 10 years or 5 years. Mineralocorticoid action like desoxycortisone acetate, early onset of hypertension with hypokalemia, and acromegaly, clinically very easy to diagnose. Out of 10% secondary causes of hypertension, 8% are because of renal artery stenosis. And therefore, it is worth to look at it, to suspect it at the younger age, or when elderly people get very severe hypertension. I use the word accelerated hypertension, sudden and persistent worsening of the previously controlled hypertension. Resistant hypertension, malignant, means patient now have changes in the, I said in the beginning that these patients primarily they do not get involvement, but with the malignant hypertension there's a small segment, 5 to 10%, who get the target involvement, and the fundus changes could very advance. Azotemia, unexplained atrophic kidney of the one size, could be hypoplastic kidney, could be agentic kidney, and unexplained renal failure. Flash pulmonary edema, this is important, and we sometimes have missed this patient because we fail to diagnose and they deteriorate because of this condition. Atherosclerotic, quite common, 90%, and Dr. Mohan group, they already, when they do angiography, now there used to be long back a tradition that you pull down the catheter below and you flush and look at the renal artery as well. And then you can stent also there. But there could be fibromuscular dysplasia seen in the young female, bead-like appearance, perimedial fibroplasia, focal stenosis, And a lot of surgical interventions done now depends on whether it is very close to a stump or long stump or beaded stump or thin stump. And then accordingly, either it is done the revascularization or graft or even stent. There could be aortorenal dissection. Vasculitis very common. There could be arteriovenous malformation and irradiation of the renal artery. Now when you use deep ray X-ray therapy, scleroderma, systemic sclerosis can present. And in 50s, there were a lot of publication with Dr. P.K. Banerjee at the KEIM Hospital and Dr. M.K. Chetri from the Kolkata. And we have some very old publication. Lot of patients of orthoarthritis, non-specific orthoarthritis. Tuberculosis was thought to be one of the important factor. Now nobody thinks about it. But then the female patient with lot of previous diseases of the collagen system used to suffer. And we had middle aortic syndrome. We had abdominal aortic syndrome. These patients present with the vasculitis, different type of vasculitis, large artery vasculitis, Takayasu disease, who had the renal artery stenosis can present with difficult hypertension. So the clinical finding, difficult to control hypertension with renal failure, progressive renal insufficiency, acceleration or malignant changes, severe diastolic blood pressure with an asymmetrical kidney, paradoxical worsening of hypertension with diuretics, onset of hypertension occurring patient younger at more than 30-year-old, and symptom of atherosclerosis disease elsewhere. These are the MR angiography now very easily available at most of the hospitals and government institution and the tertiary care hospital. You can make quick diagnosis. One can use renal artery stenosis duplex sonography and can differentiate between the velocity and the flow. This is the old technique, and we all have learned about the renogram. There is a vascular phase, there is a phase of the GFR, then there's the tubular phase, and accordingly you can know where is the stenosis, whether it's a primary renal disease or it's a small kidney, or it could be a functional, physiological, normal hypoplastic kidney, congenital hypoplastic kidney, Asthma kidney, which has the potential with a small hypoplasia, but full functioning physiology still could be at a cause of the hypertension. Fibromuscular dysphasia versus atherosclerosis is like dysplasia, which is one of the cause of hypertension, could be seen as early onset of severe hypertension with diurnal variation and deterioration of renal function. But it could be atherosclerotic variety also, rise in creatinine following induction of ACE inhibitors and progressive renal failure, proteinuria. ACE inhibitors and ACE ARBs could be very bad for these patients who have a unilateral renal artery stenosis. Very quick rise of serum creatinine if you get such patient. Otherwise control, sudden flushing, rise of the serum creatinine, suspect renal artery stenosis, stop AC or ARB, and you can even do simple vascular Doppler, and this could be also able to diagnose. What is the diagnostic recommendation now? We have a MR angiography, class 1, level B. Then you can do distal subsection angiography, 2B class, level C. Scintigraphy, plasma renin measurement, little difficult to do, but older times our teachers used to talk about it, doing the what we call as the split renal function test, catheterizing the renal vein and the artery, getting the renin ratio, and then making the with AC provocation. Now it is not done because we can do better non-invasive technique, can get the diagnosis. AC and ARBs are recommended for treatment hypertension associated with unilateral RAS. Now this is one of the point of concern. We nephrologists do not still believe that AZ and ARB should be given in the patient who got unilateral. But if it is renin dependent, and you can demonstrate it, that with the renal artery stenosis, this patient kidney is renin dependent, and this is the culprit kidney, accordingly, you can go for surgery. But if both kidney have got equal perfusion, it's not bilateral, both kidney have got hypoplastic equal perfusion with high renin, then ACE and ARBs could be used. Then calcium channel blocker, beta blocker, and diuretics are recommended for treatment of hypertension with renal artery disease. ACE and ARBs may be considered in bilateral severe. I said it before, but for the first recommendation, I doubt still. And I, as a nephrologist, would not be recommending. I have a patient, the former vice chancellor of one of the university, and this patient had unfortunately unilateral renal artery stenosis and gets severe rise in serum creatinine with initial first dose of the ACE and ARBs. So we try to keep our hands off. Let Dr. Mohan give his comment, and subsequently we'll talk about this. Revascularization, again, surgeons choice, but it depends on the duration, it depends on the segment, it depends on the whether it is a beaded appearance, whether it depends, you can put a graft or you can do auto-transplantation. Some of these patients require auto-transplantation. Then there could be sign of renal impairment related, and people have gone in for the nephrectomy, balloon angioplasty, which, and also in indication for revascularization surgery. It's not very successful. Somehow there has been a lot of experiment before, but though this is a recent publication, 2018 European Heart Journal, for some reason, physicians believe that this has not been, you do it, it reverts, it comes back again. What are the drugs and other substances with potential to induce exacerbated elevated hypertension? NSAID is very bad. Oral contraceptives, and I was talking to you about the lady before half an hour I examined, and she was on a lot of misuse of oral contraceptives, can deteriorate the condition. Sympathomimetic drugs, cyclosporine, we understand now CIN can produce hypertension. Tacrolimus, another which we use for immunosuppression in the transplant patient. Erythropoietin, very bad. In this country, we never had ideas about in 80s how much erythropoietin to be used for these renal anemia, and we used to give a lot of injection and they used to have a hell of the problem. But now we understand that erythropoietin, we give a very modest dose. Endothelial growth factor inhibitors, alcohol, cocaine, amphetamines, antidepressants, glucocorticoids, and mineralocorticoids. Should I refer to a specialist? Consider when a secondary cause of hypertension, and choice of a specialist should be based on underlying causes. Should prompt referral for the younger hypertensive patient. More than 30% rise in serum creatinine level after initiation of ACE inhibitor, and the discrepant size of the kidney is an important hallmark to consider that this patient could have renal artery stenosis, and this is a wise decision. I'll quickly talk to you about the Cushing syndrome, which is clinically very evident, and you can make a diagnosis clinically with the buffalo hump, with the face, striae, obesity, and more than 70% have pituitary ACTH. There could be ectopic ACTH, but the neoplasm 10%, and patient could be ACTH independent, and we do a Materopon test. And treatment is, and we have a patient and you do it, sphenoidal surgery, cure is almost 70 to 80% and can last for more than 10 years. One can use cabergoline, which is dopamine agonist. One can use pasirelotide, which is a somatostatin analog, and they are available in some of the tertiary care institutions in the corporate hospital. One can do adrenalectomy, surgery, and the drug. So Cushing disease is reversible. You can revert both. You can revert the hypertension, you can revert the obesity, you can revert sometimes even the diabetes. What are other catecholamine producing tumors? Quickly, it could be neural crest tumors and can be like neuroblast based, could be ganglioneuroma, could be intra-adrenal, extra-adrenal, pheochromocytoma. Pheo used to be very popular diagnosis in the previous years. The prevalence could be 0.01 to 0.3% on autopsy, and incidence 2.1 million per year, 2.06 million per year. This is clinically unrecognized, and lot of patients, close to 17% of all the cases in the so many last 3 to 4 decades, one can think of. This is now because, as I said, you have a SPECT and good nuclear imaging, so you can localize the FIOs, whatever side they have. We very rarely see FIOs at the along the lumbar vertebrae, could be sometime into the mesentery, could be sometimes the bladder. You can have a pheochromocytoma of the bladder. I had patient in my DM examination at 2 different places, PGI, Chandigarh, even at AIMS. We got, and we have seen the response very good. Cushing syndrome, you can diagnose by looking at the facial expression, buffalo hump, moon face, a lot of sweating. This is the flow sheet. Think about the ectopic Cushing syndrome based on the CT scan, and then you can do metabolic study with MRI, with PET scan, and gallium PET. You can make the diagnosis quickly. So take-home message would be that secondary hypertension is common cause of hypertension. Close to 10% of hypertensive patients, its failure to recognize secondary cause can lead to resistance and the cardiovascular complication. See either in the younger patient or patient at the advanced age. Older adult primary aldosteronism, sleep apnea is one of the important components, and we must use brilliantly to screen these tests. And treatment of the secondary causes can lead to better clinical outcome, even can revert hypertension. So thank you for your patience listening. We would take the question, I think, at the end of the presentation, or whatever Dr. Mohan thinks.
Thank you, Dr. Pathi. That was a wonderful overview of secondary hypertension, and I'm so happy that you have covered almost everything which we need to know, and in a more practical manner. The issue actually here is that routinely people are uncomfortable when they encounter a secondary hypertension unless it is renal parenchymal, or it is renovascular, or it is because of aortoarteritis or coarctation. These things are easily manageable. Problem arises for endocrine and neurogenic hypertension. I think the vascular hypertension also, there is a big issue, especially with the cardiologists having done a lot of randomized trials in atherosclerotic renal vascular disease and found no benefit. Neither there is actually improvement in the kidney function, nor the blood pressure control becomes better in majority of these individuals. And we had good number of randomized trials, and that is why routine revascularization has become actually is not recommended any longer. I think before we go to, we'll have some Q&A here till our other faculty joins us and she's able to present an interesting case of management of hypertension and stroke, Dr. Shilaja. I would ask Dr. Ravindra Mehrotra to make some comments with regard to endocrine secondary hypertension.
Thank you for the opportunity. I would like to thank initially Dr. Pathi for a wonderful presentation of the endocrine causes of hypertension. As Sarah said, basically the approach has to be more of clinical based. We cannot investigate all the patients with all the tests. If you go by the list, the most common to be picked up is hypo or hyper can be picked up very clinically. You can see palpate the gland and look at this feature, then say the patient is hypothyroid or hyperthyroid. And the tests are very, very simple to look at that. Then come the parathyroid problems. Again, we do see parathyroid patients coming to with other features, like they come to us with fractures, hypercalcemia causing the renal stones. So we do find hypertension in them. Their pure per se undetected hyperparathyroidism causing severe hypertension is not that common. Then we come on to 3 main causes: the aldosterone producing tumors, the Cushing's, and the FIOs. Now, as I said, the aldosterone producing tumors do not produce too much of symptoms. Hypokalemia is only present in 10 to 15% of patients. So 80 to 90% patients will have hypertension of aldosterone producing tumor, but no hypokalemia. So there we go by the looking at the patient's classification as resistant hypertension or not. That is somebody requiring more than 3 drugs and the patient is still uncontrolled, or requiring 4 drugs to control the patient, onset at a younger age, or having end organ damage at the younger age, like stroke or LV hypertrophy occurring at a younger age. That will give rise to a clue of aldosterone producing tumors. And the testing is initial testing depends upon the looking at a sample of PRA, the plasma renin activity, or plasma aldosterone concentration. Now, this is a very kind of commonly done test these days now, but the only thing, interpretation is a little difficult. Now, these patients will be on multiple drugs. They'll be on ARBs, they'll be on diuretics, they may be on beta blockers. So initially it was said that we should stop all these drugs to look at the values. But to change the medication at that point of time and then again control the patient, control the potassium, and it takes a long time to do it. So now the protocol basically says that we can do a basic plasma level of aldosterone and PRA at the very first day or second day of the evaluation. Don't change the medication. Suppose somebody is on ARB. On ARB, we expect the renin to go up. But still, on if the patient is on ARB and the renin cells suppressed, that gives a very strong clue that patient may be having an aldosterone producing tumor. Or if patient is on diuretic, again in diuretic, we expect the renin activity to go up. But patient on diuretic and the renin activity is still suppressed, again a pointer toward the aldosterone producing tumor can be there. The calcium channel blockers can suppress the aldosterone levels. So that they may have to be, you do it in case the PAC is coming low, then remove that drug and repeat the test after 2 to 3 weeks again. Similarly for beta blockers. Beta blockers will suppress the PRA and suppress the renin activity, both will get suppressed. But the renin activity is suppressed more. So in case you have interfering drugs, you look at the basic values and try to interpret. If you can interpret, fine. That means in the case the aldosterone concentration is more than 20 and PRA is less than 0.1, your diagnosis is very, very clear. In case the values are not that high, in that case, stop the drug and repeat the test after 2 to 3 weeks. This is only a case finding test. After that, you may require a confirmatory test by doing a sodium loading test. That normally we do it. And then come for an angiogram, but they look at the CT scan and they look at the April sampling required or not required. That is a different way of classification. Then comes the FEO. Now, FEO basically comes to us with a lot of symptoms. They come with headache, giddiness, vomiting, and palpitations. Whenever you have this triad, we do the collection and urine collection for the fractional metanephrin. So whenever a suspicion is low, we look at the urinary fractured metanephrin. That is the most common thing to do these days. Look at the assay there. That is very important. Simply doing an ELISA may not give you a good test result. It should be a HPLC or a mass spectroscopy to give you a good result of fractured metanephrin. Another thing is the Cushing. As I showed you the diagram of Cushing syndrome. In case and the whether it is a Cushing syndrome caused by pituitary disease or ectopic Cushing or the real Cushing, they all will cause hypertension. There are multiple causes for the Cushing syndrome causing hypertension. And the diagnostic rhythm is algorithm is very clear, and somebody can refer to an endocrinologist. They will diagnose where the problem lies, and the patient can be treated. Now, what commonly we're seeing now these days is the patient undergoing scan, like especially the COVID era, we have a lot of patients undergoing CT scan of the chest, where we do find the adrenal part is being imaged in that. The patient has hypertension, and patient has picked up to have an adrenal SOL. That's called incidentaloma. That has to be worked up for all the 3 lines which can cause hypertension. We look for the aldosterone causes, we look for the PO, and we look for the Cushing disease. Other than that, the rare causes that I said about the 7-beta hydroxylase deficiency or 11-CH is not that common, but we do see them. As I said, one case in maybe 5 to 6 years, we do see them. We do have a family which comes to us 1 in 5 years to get picked up. But in case you have a suspicion is there, you should always have a high index of suspicion. The family history program is very, very important. If you have a good family history or a good history estimate taken, good examination has been done, then your approach becomes much more simpler. Thank you, sir.
Thank you, Dr. Mehrotra. I just, before I go to Dr. Chandan Mishra and ask him his views, do you have a very simple algorithm for endocrine hypertension that this is the bare minimum thing you should do? That's bare minimum thing you would do.
Again, the approach will have a strong backup of the history and examination. So that will differentiate a lot of causes. Whether should I do this or do that? In case you have practically only kind of resistant hypertension, so what we do is we can do a plasma aldosterone concentration and a PRA ratio, 24-hour urinary cortisol or an overnight suppression test for the cortisol for suppression axis, and a 24-hour fractionated metanephrines with electrolytes, TSH, and calcium. Practically, you will pick up more than 95% cases of endocrine hypertension in this kind of list.
Thank you, Dr. Mehrotra. I think that was wonderful. I think you rightly said that the PRA, the urine test for VMA, urinary cortisol level, and PTH levels and calcium phosphorus will help us in picking up good number of cases. I think that is a message we would like to give to our colleagues who are listening to us. And I'll ask Dr. Chandan Mishra to make his views on this whole aspect of secondary hypertension to us. What does he think? Is it sufficient? More needs to be done? What is his way of looking? Does he look from intervention cardiologist perspective at coarctation, the mid-aortic syndrome, the renal arteries, and elsewhere? What is it?
Excellent presentation, Dr. Tripathi. We, the busy practitioners, usually skip the secondary causes and started treating patient as like essential hypertension. But most of the patients are usually not responding, and then we think that it is a case of resistant hypertension, and we do starting treatment with multiple drugs. So basically, though the number of cases of secondary hypertension is very minimum, but we should always think if the patient is not responding with more than 3 drugs, including 1 diuretics, we always think of a secondary cause, especially in young patients less than 25 and more than 55 years. In renal causes, usually when we do angiography, coronary angiography in resistant hypertension or patients not responding, we usually do renal angiogram and see whether renal artery stenosis are there or not. If renal artery stenosis are there, though the results are not very promising, except in some cases, we usually try renal artery stenting in some cases to get a good response. In other cases, though renal sympathetic denervation we have started in SSKM hospital as a part of the simplicity trial, but the results was not good, and the treatment is still going on. The renal simplicity trials are going on, though in first cases there was no response or less response, but some trials are in favor and some trials are against. So these things are basically for resistant hypertension, but for secondary hypertension we should think when the patient is not responding and when there is specific symptoms for the specific causes, and when there is deterioration in a case of renal artery stenosis with AC or ARBs, where increasing potassium, or the patient is not responding, or patient is going to renal failure, then we could think of renal artery stenosis. Other cases of like obstructive sleep apnea, we can easily recognize the patient. The patient will give definite history of snoring, the patient will be obese, there is multiple bouts of hyperapnea syndromes in the night, and this patient is definitely responding to CPAP therapy. In other cases like chronic kidney disease or other, in early age, there should be glomerulonephritis or other rapidly progressive glomerulonephritis. Those patients, some patients are going to early chronic kidney disease, and some patients are are responding well to steroids or other immunosuppressive therapy. So we should categorize them. If there is no permanent or hypertension or resistant hypertension, then we can treat them according to the resistant hypertension guidelines, or we think of other therapies. And we should specifically target the cause of the secondary hypertension. Dr. Mehrotra has detailed discussion for endocrine causes. I think other causes like neurogenic causes or other causes, or the causes which are very difficult to diagnose in the clinical setting should be discussed upon later on with few question and answer. Thank you. Thank you.
Dr. Mishra, thank you. As we have now moved from transfemoral approach to transradial approach, the drive-through renal angiographies have fallen down considerably.
Yeah.
You know, we used to do a lot of renal angiography when we were using a femoral approach, and older people like me have also shifted to radial approach, transradial approach. And
I also do.
This thing. So luckily we are not overdoing any more renal angioplasties, and that is a good thing.
Yeah.
A question to you as well as to Dr. Tripathi. One single question. First, I'll ask Dr. Tripathi to respond. In this whole gamut of secondary hypertension, where would he, when would he, how frequently he would get polysomnography in hypertension? Polysomnography. Dr. Tripathi.
Yes, most of those obese patients who snore, number one, metabolically they are obese and they have shown signs of insulin resistance, number two, and have the daytime somnolence. I would suspect that they should one who should go for polysomnography. And they have yielded the result. And these patients have difficult to control hypertension as well.
Dr. Tripathi, those are too obvious. You know, these things are too obvious. The issue actually in front of us clinicians is where the people are lean and thin and you least suspect how often, how frequent, where in the algorithm you would be suggesting to do polysomnography. What you have described, each of us knows it. Actually, every physician, every MBBS doctor knows it. Thick individual, obese individual who is snoring at night or who is somnolent in daytime should have a polysomnography. I mean, the question is, in a person who has a difficult to control hypertension and does not have these features, where would you place polysomnography in the entire algorithm?
I haven't gone through any such of algorithm which is discussed by any society of cardiology or endocrinology. But I personally believe, looking at the analogy and making things together, that the patient also have some component of insulin resistance. Maybe endocrine colleague can answer it, Dr. Mehrotra can answer it. Most of these patients who have got very difficult, very severe insulin resistance, who have got also obstructive sleep apnea and have got difficult to control hypertension. Maybe that is one of the guideline, lean and thin. If patient is lean and thin, requiring more drugs to control the hypertension, does not have other associated factor, there could be one. Maybe Dr. Mehrotra could be answering it.
We keenly look for Dr. Mehrotra's advice on that.
Looking for the markers of insulin resistance in the patient is again a clinical thing. Look for the BMI and look at the visceral adiposity. The Indian basically have more of visceral adiposity, more of like in the abdomen rather than being classically obese. If you look at the BMI cutoff for India, Asian population, if the BMI is more than 23, you can be calling them overweight, which is very much different from the Caucasian population. So if you have more of waist-hip ratio, if you have more of skin tags, a small kind of skin tags on the neck or in the armpits, look for the acanthosis, again a very marker of insulin resistance. If these things are there, even though he may not have a classical obesity, he can be clinically said to have insulin resistance. Acromegaly, basically patients have a lot of sleep apnea. So there, in case somebody has a history of we are looking for sleep apnea, we do always look for the acromegaly or GH excess in these patients.
Dr. Mishra, your viewpoint on this routine use of polysomnography in unearthing the cause of difficult to treat hypertension?
If there is no definite history of snoring or definite history of apnea by the relatives or the patient itself, or if there is no daytime somnolence, it is very difficult to advise them for this polysomnography. Only things, the lean and thin patients who are giving clear history, they are not responding to treatment. I think there is no such guidelines that when we would give directives to them, lean and thin patients, resistant hypertension patients, to do polysomnography. It's a individually directed subjective things, and we think the patients, lean and thin patients who are not responding, and the patient's party giving history or patient itself giving history of such snoring, we should go for one time this polysomnography to judge whether it may be a cause. Thank you.
Dr. Mishra, another point which I want to ask before, I also actually want to address these questions to Professor Sailja, but before I come to her, I again want to ask you one question. In secondary hypertension, is there a role of ambulatory blood pressure monitoring?
Definitely. We have to see whether nocturnal dipping or morning hypertension is there, and we can judge this. We can fix the dose accordingly. If they are non-dippers or they are morning surge of hypertension, we use the drugs which are useful for 24 hours, and also we can judge whether which morning and evening ratio of hypertension or morning surge or evening surge, these things can be determined, and we can easily determine the dose of the medicines and also the type of the medication which we should use for the individual patients of resistant hypertension. Thank you.
Yeah, Dr. Mishra, the reason I asked this question was, it has been said that people with secondary hypertension have they are more often non-dippers and reverse dippers. And hence, in a person who is a non-dipper, reverse dipper, you may be more inclined to investigate this patient for secondary hypertension, maybe including polysomnography, maybe doing a PRA, maybe looking at the cortisol to cortisol ratio, and so on. Dr. Tripathi, sir, your view on that about ABPM and secondary hypertension?
Yes, that I said in the beginning also, and that's quite true also, that these patients who are non-dipper and they have a early morning, there is a rise or there is a exacerbation of the hypertension, number one. Number two, these patients, because of the poor perfusion into the kidney, they require much more drug than cytomas. There could be intrarenal tumors, secreting tumors. So that's how you differentiate between the two. And there still keeping that into the renal hypertension or the other than. Yes.
Thank
yes,
you,
sir.
Dr. Tripathi. Professor Sailja, you have any comments on the things I have talked to, polysomnography, ABPM in resistant hypertension and difficult to treat hypertension? No, I'm sorry, the secondary hypertension and ABPM, and any simple algorithm for managing a diagnostic algorithm for secondary, any of your views? I'm sure neurologists see a lot of patients with hypertension and they are as good hypertensionologists as we claim ourselves to be, and I would be very keen to listen to your views about this.
No, sir, I don't think neurologists are very good people to treat the secondary hypertension, because most of the time when it comes to very refractory hypertension, we get the help of the cardiologist to manage them. But we tend to see a lot of these patients with secondary hypertension and very uncontrolled hypertension patients coming with both ischemic and hemorrhagic strokes. And especially hemorrhagic strokes are very common in the younger age group in the secondary hypertension patients. So I don't think I have got any other extra opinion rather than all the leaders in those areas speaking on hypertension.
Thank you, Professor Sailja. I think we would have some more Q&A after your presentation, and we are keenly now awaiting your presentation, management of hypertension in a patient with stroke. We certainly want to learn this area. We definitely feel that this is an area where we can get your help and be wiser, because cerebral perfusion is something which we cardiologists don't understand that well, and I'm sure my endocrinologist colleagues and nephrology colleagues will also agree that we are not very good in understanding this cerebral autoperfusion and cerebral perfusion and hypertension. So, Dr. Sailja, the floor is yours to discuss your cases.
Can I share my screen?
And be wiser. Slides are visible. Please go ahead.
So good evening. Thanks to Dr. Mohan for the kind introduction, and thanks for inviting me for this meeting. So we, as been told by the chairperson, we are never bothered about acutely bringing down the blood pressure. We are more worried about not to bring down the blood pressure, especially in a setting of acute ischemic stroke. But when it comes to hemorrhagic stroke, the thinking process is totally different. What I'm going to do now is just introduce to the audience with regard to the feel of how we think about hypertension in acute ischemic stroke and hemorrhagic stroke, and bringing in few case scenarios and how we go about managing these patients in the acute setup. We know that in acute stroke, whether it is ischemic or hemorrhagic, at least 3/4 of the patients will have high blood pressure in the acute phase, especially in the first 24 to 48 hours. And it is also important to understand that in 2/3 of these patients, over the next 48 to 72 hours and over the next 1 week, the blood pressure spontaneously falls down even without any other treatment. And there is already well described a U-shaped relationship between the baseline blood pressure and the outcome, suggesting that very high blood pressure and very low blood pressure has been shown to be associated with poor outcome in the form of mortality and also dependency after stroke, both ischemic and hemorrhagic. The optimal management of hypertension in patients with acute stroke still remains controversial. As has already been told, the cerebral autoregulation is one important point we need to understand. There is a cerebral autoregulation by which the cerebral blood flow is maintained even with the during a cerebral perfusion pressure of 50 to 150. But once the patient has got an acute stroke, whether it is ischemic or hemorrhagic, this autoregulation is impaired. And hence, because of that, the cerebral perfusion pressure and the cerebral blood flow will be directly related to the blood pressure. And what happens is, once there is a very high increase of blood pressure, there will be increased blood flow to the brain, which can lead on to vasogenic edema and also hemorrhagic transformation or increase in the hematoma. And if the blood pressure comes down, it can lead on to arterial collapse, leading on to ischemia and extension of the infarct. So it's very important to understand the pathophysiology of ischemic stroke to really know what we are talking about with regard to the importance of not actively controlling the blood pressure. For example, in an acute ischemic stroke, when there is a major vessel occlusion by a thrombus, immediately within minutes, there is an area of the brain which becomes irreversibly damaged, which is called the core of the infarct. surrounding this core, there is an area of penumbra where the neurons are inactive, but they are not irreversibly damaged. This is a tissue at risk, and once you open up this blood vessel, the penumbra is the area which can be salvaged, and thereby the core of the infarct will be low, the infarct volume will be reduced, and that will reduce to less morbidity and mortality. The way this penumbra is going to be maintained is partly through the collaterals too. So there is a major vessel occlusion. Through pile collaterals or leptomeningeal collaterals, there will be a blood flow which is happening to the areas which are, even though occluded, through these leptomeningeal areas, the collateral supply will salvage a good number of the brain cells. What happens when the blood pressure comes down? The collaterals will fail, and this can lead on to increase in the infarct. So let us go to the first case. This is a 55-year-old hypertensive who came to the emergency with an acute right-sided weakness and aphasia about 18 hours after the onset of stroke. So on examination, the patient was conscious. There is a National Institute of Health stroke scale. This is a stroke severity scale which we use, by which we tell the stroke severity, whereby it is divided into 0 to 42. So 0 suggesting that the patient is completely normal, and 42 is the most severe stroke. So when you have a NIHS of 16, that suggests there is a moderately severe stroke. You know, there is a global aphasia, dense right-sided weakness, that is a big stroke. The blood pressure in this patient was 180 by 100, and the random blood sugar was 150. This is the CT scan of this patient. You can see that it is a left MCA stroke. You can see there is a hypodensity which is seen in the right middle cerebral artery territory. And this is the evolved infarct which you are seeing. And this suggests that within 18 hours of onset, this patient has already developed a significantly big infarct. And we did a CT angiogram to look at the vessel, and you can see the left MCA, there is a thrombus which are cut off. So what this suggests is that this patient has got a big stroke with a left MC middle cerebral artery occlusion. And in this patient is out of the window period for intravenous thrombolysis. Even though mechanical thrombectomy can be given up to 24 hours, this patient already there is an evolved infarct, and hence this patient is not a candidate for mechanical thrombectomy too. So this patient was started on antiplatelets and statins. The major question is, this patient's blood pressure was 180 by 100, and this was progressively increasing to 190. On most of the time when there is a major vessel occlusion, these patients tend to have very high blood pressure. Do you really want to treat this blood pressure? So if you look at the evidence, you can see that, as I've already mentioned, blood pressure will be elevated in acute stroke, both ischemic and hemorrhagic. But whether we should treat this blood pressure acutely is still a debated question. But whatever evidence we have from randomized controlled trials show that there is no need to actively treat the blood pressure in the acute phase of stroke, because the high blood pressure is mostly related to multiple factors. It may be related to a neuroendocrine stimulation, it may be because of the raised ICP producing a Cushing reflex, or it can be a part of the stress of hypertension. Why you do not want to treat the blood pressure in acute phase of ischemic stroke? Because if increased blood pressure is required to maintain the penumbra, which I have already mentioned through the collateral circulation, you bring down the blood pressure to 120 or 130, you are going to have a failed collateral, thereby the whole MCA territory is going to get infarcted. But at the same time, you do not want a very high blood pressure of 220 in this patient, because very high blood pressure can produce, it can produce significantly increased cerebral blood flow, which can lead on to brain edema and hemorrhagic transformation. So there have been many trials which have been done, which has looked at the blood pressure lowering versus no lowering. And all these studies have done in the acute phase and has found that these were either neutral or negative, and there is currently the evidence do not favor acutely bringing down the blood pressure in the patients with acute ischemic stroke. This is a meta-analysis which has been done as looking into the blood pressure lowering agents in the acute phase of early ischemic stroke. where the patients have been treated in the acute phase versus no treatment. And as you can see here, there was no significant benefit by treating these patients actively with antihypertensives. So if you look into the guidelines, you can see that, so currently how we manage patients with acute ischemic stroke is, if a patient is having an ischemic stroke, the patient is not in a time window to treat with intravenous thrombolysis or mechanical thrombectomy, you need not bring down the blood pressure acutely if the blood pressure is up to the range of 220 by 120, unless there is a reason from the acute coronary event or an aortic dissection, or a patient is a thrombolysis candidate, you need to bring down the blood pressure. Otherwise, there is no need to bring down the blood pressure, and it is not going to produce any damage to the patient. But if the blood pressure is going beyond 220 by 120 and the patient is not a candidate for intravenous thrombolysis, it is important to bring down the blood pressure below 200. Usually we bring it down to 200, and there is no need to give IV acute medication to bring down the blood pressure down by giving us sublingual or an IV medication. You need to bring it down fully slowly. And coming to restarting of the antihypertensive medication, it is always better to wait for at least for 24 to 48 hours or even up to 72 hours, depending upon the stroke subtype. What I mean by stroke subtype, which I am coming to later, where your patient has got a major vessel occlusion, like a tight carotid stenosis or an intracranial stenosis, you do not want to bring down the blood pressure significantly low so that you produce an extension of the infarct. But at the same time, hypotension and hypovolemia should be always corrected, because there is enough data to suggest that if there is hypovolemia and hypotension, there can be extension of the infarct and you can produce more damage to the patient. So what is important to understand is that if a patient has got an acute ischemic stroke, the patient is not a candidate for any revascularization therapy. You need to acutely bring down the blood pressure only if it is more than 200 to 220. Coming to the second case, this is a 54-year-old male with a risk factor of hypertension, coronary artery disease, and chronic smoker, who came with an acute onset of weakness of the right upper and lower limb at 8 a.m. And this patient presented to us 1 hour 35 minutes after the stroke onset. And examination, the patient was conscious with a global aphasia, right-sided weakness, dense weakness with the right hemiplegia, and the blood pressure in this patient was 210 by 110. So this is the CT scan of this patient. So the patient has come to us very early, within the first 3 hours, within the therapeutic window period for thrombolysis. This is the CT scan of this patient, which shows a good aspects. What do you mean by aspects? Is there is very less core in this patient. That means the scan is very good. We have got a big penumbra to salvage in this patient, suggesting there is very early ischemic changes alone with a big penumbra to salvage. And we did a CT angiography, which is a protocol to look at the major vessel occlusion to decide whether after intravenous thrombolysis, whether the patient should go for a mechanical thrombectomy. In this scan, you can see that the left MCA, there is an abrupt cutoff of the middle cerebral artery, suggesting that this patient has got a major vessel occlusion. So here is a patient with a very good scan, came in the time window to treat, and this patient is an ideal candidate for intravenous thrombolysis. And in this patient, we gave lebetalol 10 milligram every 10 minutes. After 3 doses, the blood pressure came down to 170 by 100. After which the TPA bolus was given, followed by infusion. And following the TPA infusion, while after the bolus, the patient was immediately shifted to the mechanical thrombectomy to the cath lab. So the protocol is, after intravenous thrombolysis, in the next 24 hours, the blood pressure needs to be maintained below 180 by 100. This is mainly because the blood pressure, if it is high after thrombolysis, there is data to suggest that it increases the risk of bleeding into the brain, and this can definitely worsen the patient. So this patient underwent a mechanical thrombectomy and opened up the vessel, and this is a scan of the patient with a very good recovery and a complete recovery, and the patient was discharged ambulant without any support. So compared to a patient who is not a candidate for intravenous thrombolysis, if a patient is a candidate for thrombolysis, the blood pressure should be rapidly brought down within minutes and here we need to give either labetalol or you can give intravenous nitroglycerin if the patient there is a contraindication for labetalol. Otherwise, usually we prefer labetalol. And once the blood pressure is below 180, we can treat these patients, and it is important that the blood pressure is maintained in that level for the next 24 hours to prevent reperfusion injury. What we mean by reperfusion injury is the blood-brain barrier is disrupted in the infarcted area, and a sudden increase in the blood pressure can lead on to hemorrhagic transformation of the infarct in the acute phase. So this is a study which has been done to look at how intensively you should bring down the blood pressure during intravenous thrombolysis, whether it's 180 below is enough or you should bring down very aggressively to below 140. And this data was looking at the intensive versus the guideline-based blood pressure reduction. And it was seen that there was no significant difference between the two, suggesting that we are still now following the guideline-based reduction of the blood pressure to a systolic blood pressure of less than 180. So what is the current guideline for systolic blood pressure reduction? For endovascular treatment, what I told initially was intravenous thrombolysis. Even if you are taking the patient to a cath lab, you keep the blood pressure below 180. And after the procedure, how low to bring down the blood pressure will depend upon how well you have opened up the vessel. For example, you have received a complete recanalization. The vessel is completely opened up. You can significantly bring down the blood pressure to 120 to 140. But sometimes the recanalization may not be complete and the vessel is only partially opened up. Depending upon whether it is a complete opening up of the vessel or a partial opening up, you decide how aggressively you want to treat the blood pressure after the thrombolysis. The management of the hypertension, I don't think I have to discuss regarding it. We use labetalol. Otherwise, in those situations, we use, like the blood pressure is very high, we tend to use sodium nitroprusside. This is a third case. This is a 55-year-old hypertensive who presented with a right hemiplegia and aphasia. And the patient reached the hospital 3.5 hours after onset. On admission, this patient was mildly drowsy. The blood pressure was 190 by 100. And the patient has got a moderately severe stroke. And this is a CT scan of the patient. As you can see here, there is a big bleed, which is a basal ganglionic bleed of around 35 to 38 ml, suggesting that it is a spontaneous intracerebral bleed due to hypertension. In this patient, compared to an ischemic stroke patient, there is a great need to aggressively treat the hypertension in this patient. Because after a bleed, the hematoma expansion happens in the first 3 to 6 hours and it goes on expanding usually up to 24 hours. And blood pressure control is one of the important factors which limit the hematoma expansion. This patient, we had to aggressively bring down the blood pressure with labetalol. Even after labetalol, it was not coming down. We had to start NDG infusion in this patient. And this is a repeat CT of the patient. In those patients where the blood pressure remains very high, uncontrolled with a lot of blood pressure variability, invariably they're going for an expansion of the hematoma. And here we can see that the 24-hour CT, there is a big bleed in this. The expansion of the hematoma can be seen. So high blood pressure is an important predictor of hematoma expansion, similar to hyperglycemia or coagulopathy, and age. All these are factors which increases the chance of hematoma expansion. So any hematoma expansion is likely to worsen the patient, the brain swelling is likely to increase, and the patient is likely to have an increased morbidity and mortality. The IV administered antihypertensive medication is the same as what we described for the other one. So if you look into the guideline compared to ischemic stroke, we are very aggressive in bringing down the blood pressure in patients with hemorrhagic stroke. We need to acutely lower the blood pressure to 140 below, especially if the patient is coming to us within the first 24 hours and within the first 6 hours. And if the patient is having a blood pressure of more than 220, it is always better to bring down the blood pressure by continuous intravenous infusion. But you need not bring down the blood pressure very low to below 120 or so, because there is some theory there may be a perihematomal ischemia, which is not very true, but ideal would be to maintain around 140 below, so that you prevent the hematoma expansion and a patient is likely to have a better outcome. Another important question with regard to antihypertensive medication is most of, at least 50% of our patients with stroke have hypertension as a risk factor, and many of these patients will be on antihypertensive medication. So in these patients, do you want to aggressively, do you want to stop?
11,622 रुपए की दवा ये देखें 32 लाख की आई.
Can you unmute, please? So, so you can see that whether there is a need to continue or temporarily stop the medication, antihypertensive medication. This is a meta-analysis which was done with 2 randomized controlled trials, which have shown that temporarily discontinuing the medication and stopping the pre-stroke antihypertensive medication is unlikely to produce any issues for the patient, and this is unlikely to create any bad outcome for these patients. And so what we routinely do is we never keep these patients, we start the medications, or we do not continue the pre-stroke medications in these patients, because in that first 24 hours they are in a very unstable state of blood pressure, and we do not want any hypotension in these patients. So this is the 4th case, this is the last case, and I will finish in the next 2 to 3 minutes. So this 4th case is a 68-year-old patient with a recurrent left hemispheric TIA, 1 hour of 1 week duration. The patient was having recurrent left-sided weakness, which was progressively lasting few minutes and recovering. On examination, the patient had a blood pressure of 170 by 180 millimeters. The recovery was very good, and the patient had a mild hand dexterity alone. But by the time the patient came to us, there were no deficits, suggesting that all these were transient ischemic attacks. And this patient had an MRI done. As you can see here, there are multiple infarcts which are seen in the left middle cerebral artery territory. And you can see that these are watershed territory infarcts, suggesting that this patient has got embolic infarcts from the proximal source, suggesting an artery to artery embolism, and there is a hemodynamic cause, suggesting that there is a hemodynamic compromise too. You can see this is a CT angiogram of this patient showing a tight carotid stenosis, suggesting that this patient has got a tight symptomatic carotid stenosis, which is responsible for the recurrent TIA. In this patient with a blood pressure of 170, do you want to aggressively treat the hypertension? This patient was started on aspirin and clopidogrel, dual antiplatelets and high-dose statins, and this patient was planned for carotid endarterectomy. So in patients like this, if there is a hemodynamic compromise, we do not want to aggressively bring down the blood pressure. But if the patient is like 1 week later, you can slowly bring down the blood pressure, but we do not want to bring it down very low, because these patients, we can see them worsening when the blood pressure comes down very low, especially if the patients are having hemodynamic. The TIA can be hemodynamic or it can be embolic events. If the events are hemodynamic, most of the time the lowering the blood pressure leads on to worsening and developing new events. So if you look into the data with regard to the blood pressure management in carotid stenosis or large vessel occlusion, in these patients, there is no need to aggressively bring down the blood pressure to below 130. It is better to maintain a 140 to 150 level in the acute phase. And once the patient is a candidate for endarterectomy, post-endarterectomy, definitely we bring down the blood pressure low to prevent a reperfusion injury, especially if the patient is in the early phase after an acute ischemic stroke, and if the patient has got a tight stenosis where the patient is highly likely to have a reperfusion injury. So to conclude, the blood pressure management in acute ischemic stroke should consider not the blood pressure values. It depends upon what time the patient has reached you. The patient has come to you after 3-4 days, you can very safely bring down the blood pressure. But in a patient who is coming to you within the first 2 hours or 3 hours, you are not going to aggressively bring it down. Second is you look at what is the subtype of stroke. whether this patient has got a carotid stenosis which is responsible with a tight carotid stenosis, or whether the patient is having a large vessel occlusion. It may be an ICA occlusion which may be leading on to the stroke. That is going to decide, and also the associated comorbidities are going to decide. This patient has got a acute MI followed by a stroke. You are going to give importance to the acute MI too. So the comorbidities are also going to decide how low you are going to bring down the blood pressure. But with regard to spontaneous ICH, the guidelines is very clear that in the acute phase, especially in the first 24 hours, there is a need to aggressively bring down the blood pressure to below 140, because that is going to decide on the expansion of the hematoma and outcome of these patients. Thank you.
Thank you, Dr. Selja. That was concise and I think case-wise lessons, 4 different lessons we have learned. And as I recall, all you're trying to say is an acute ischemic stroke, don't lower blood pressure unless you are planning thrombolysis or thrombectomy. And otherwise the blood pressure up to 220 by 115 is okay. For intracranial hemorrhage, you have to be aggressive in lowering the blood pressure to below 140, but not too low, maybe 130 to 140. And for patients who actually have the recurrent embolization, you should look, of course, and try not to bring them down significantly. And of course, endarterectomy or angioplasty should be considered. And after you have achieved actually full patency of carotid, you can be aggressive as far as lowering blood pressure is concerned. Those are, I think, the lessons we have learned. And I'll ask my friend Dr. Chandan Mishra to comment. Do you have any views on that, sir?
Actually, this was our student life teaching that in acute ischemic stroke, in case of thrombosis, we should not lower the BP very early. We should wait for 24 hours to down the BP by 15-20% and not less than 160 by 100 in 24 hours, because of there is chance of this death of the penumbra cells. But in case of acute hemorrhagic stroke, we should definitely reduce the blood pressure to prevent the vasogenic and edema and to reduce the complications. So it's better not to reduce the BP emergently in case of thrombosis and like that. But in case of thrombolysis, we should lower the BP, and the BP should be maintained for at least 24 hours. But I will ask the speaker, after 24 hours, what will be our guidelines? Whether we should routinely start the previous medication, we should keep the BP less than 140 by 90 for the next period. Now, what should be our guidelines for next 24 hours, after 24 hours of cerebral stroke? And another question from cardiologist point of view, whether the patient was on aspirin, whether we should give aspirin or copidogrel before doing CT scan if we are in the periphery, not doing CT scan for the next 24 hours or next 12 hours or like that. Whether if there is no definite symptoms of ICH, whether we should give ecosprin or stop it till CT scan is done. And another question or another is when to start ecosprin or copidogrel after ICH or acute thrombosis. Thank you, sir.
Very good questions. So I'll take up the question of aspirin first. So for example, if you have a patient with a stroke who have never been on aspirin and you are in a situation in a primary healthcare center or where a patient has come to with a stroke and you are not having an access to CT scan, ideally you are not supposed to give aspirin in those patients when you do not have a CT scan, because even if a single dose of aspirin there is always a hemorrhagic stroke risk is definitely, it is 20% of them are hemorrhagic stroke, and clinical assessment of ischemic versus hemorrhagic stroke without an imaging, you are only 50% of the time correct. So ideally, only after a CT, you should definitely give an aspirin for a patient. That is the first question. Second is with regard to the management of these patients after they develop a bleed. So if it comes to a spontaneous intracerebral bleed and the patient needs to be started on aspirin, currently there is no definite guideline as to when you can restart the aspirin after a spontaneous ICH. It is all expert opinion based. So if you have a situation where you have a patient with a recent stenting done and the patient needs to be immediately started on an antiplatelet, after a period of 1 week, once you know that the patient's expansion of the bleed is less likely and the patient is relatively stable, you can definitely restart the antiplatelet in that patient. But in patients with dual antiplatelets, if you want to start in a spontaneous ICH patient, that depends upon how big is the bleed. If it is a lobar bleed, those factors need to be taken into consideration to make the decision. But otherwise, after the acute phase of 1 week, you are safe in starting a single antiplatelet in these patients. But restarting anticoagulation, you have to look into many factors to decide how you decide on starting the anticoagulation in patients after a spontaneous ICH. That depends upon whether it is a ICH bleed, which is a subcortical bleed, depends upon whether it is a lobar bleed with a amyloid angiopathy, or in a situation where you may be having a prosthetic valve where you may have to make your decision of restarting early because you do not want to have a valve thrombosis. So multiple factors make you to decide. But if there is no urgency to restart anticoagulation, it is always better to wait for 2 to 3 weeks and then restart the patient on anticoagulation if there is a need in the form of a non-valvular atrial fibrillation.
Thank you.
There was one more question which was asked.
Aspirin plus clopidogrel.
Yes, aspirin plus clopidogrel, definitely that depends upon whether you want, what is the indication for which you are starting. But if you want to restart in those patients, after a period of 2 weeks, you can safely start if it is a ICH, which is a hypertensive kind of a bleed.
Now, your first case, acute ischemic stroke, would you give dual antiplatelet therapy? It's a moderate size NIHS of 16.
Yes, yes.
Would you give combination? How long would you give?
Yes. There are clear guidelines for currently for acute ischemic stroke. We have got enough randomized controlled trials on how long to give dual antiplatelets after an acute ischemic stroke. The current guidelines would advise giving dual antiplatelets for a period of 3 weeks, after which you need to make it into single antiplatelet, except in situations of large artery atherosclerosis. For example, there is a carotid stenosis or an intracranial atherosclerotic disease where the duration of dual antiplatelet is for a period of 3 months, after which you make it into a single antiplatelet.
Right. Any question to Dr. Selja, Dr. Mehrotra, Dr. Tripathi?
Madam, thank you for a nice presentation. But only sometimes we are called in an emergency, post-stroke the BP is very, very high. And they ask us to look for a FEO or a catecholaminergic producing tumor. When do you think we should start looking? Normally we wait for 48 hours before we do anything, unless they have a small family history. What do you should suggest when you should start looking for a secondary hypertension patient with a stroke with hypertension?
I think if it's a patient is an acute stroke, after the period of 3 to 4 days, depending upon the stroke, once the patient is stable, you can definitely evaluate the patient further for a evaluation. And only situation where you are not going to be very obsessed about the hypertension is in ischemic stroke. So you have got enough time. Most of the time we bring down the blood pressure over a period of 1 week and then slowly bring it down.
Thank you.
Dr. Tripathi, in the chat box there are 2 questions, and I will ask you and maybe Dr. Mishra can chip in. One question has been asked, what is the role of nuclear perfusion test in diagnosis of secondary hypertension? I myself haven't understood the question, but I thought maybe you know it. You are muted, sir. You are muted.
Sorry. No, I'm open on from my side.
Okay.
Maybe others have muted me.
Yeah. All right. Nuclear perfusion scan in diagnosis of secondary hypertension. I quite don't understand the question, to be honest.
Perfusion study primarily have very little role to play. You can do nuclear scan. You can do the like glomerular phase, tubular phase, followed by the secretion phase. But if there are, this is highly academic, some case reports are there, very hemangiocytomas, those who have got, or ischemic areas, or ask upmark kidney, polar ischemia. Polar ischemia produces severe changes into the renin, and these are the culprit kidney sometimes. Very small case report, not series, not as a publication. That's the very specific area. But otherwise, renal perfusion study per se has hardly any role to play.
And another question, which again is directed to you, but I'll ask Dr. Mishra also to comment on that, role of sympathetic nervous system in hypertension, especially in secondary hypertension.
Dr. Mishra.
In case of hypothyroidism or hyperthyroidism, both, sympathetic nervous system is stimulation is the main cause for hypertension, and also catecholine secreting tumors and other tumors, they are also doing like that. So in that case, from kidneys there is sympathetic nerve ablation. There was a much furor about this 10 years back, around 10 years back, I think in 2014. There is Simplicity 1 trial which shows very much hope that it can do a wonder. But after that, gradually, it shows that it cannot do anything more than a placebo therapy or like that. So we abandoned the process. And though there are multiple studies, randomized studies are going on in favor or against, but I think sympathetic denervation has not done any wonder. Also, baroreceptor stimulation is another method of reducing resistant hypertension in case of secondary hypertension or any case of resistant hypertension. That also is in experimental stage. So, though there is much role in sympathetic nervous system stimulation in hyperthyroidism, catecholine tumor, or other things, in acromegaly also, but this the therapies directed to that has not been very much successful. But still, we have multiple drugs which lessen the sympathetic stimulation, and that also reduces blood pressure. So we should consider sympathetic stimulation in every case of resistant hypertension and give some medication to reduce the sympathetic outflow. Thank you, sir.
Yeah, Dr. Tripathi, any comments on that? I just wanted to make one point. Sympathetic nervous system plays a big role in initiation and pathogenesis of hypertension. However, that is in early phase. Once hypertension has been established, then the disease is self-sustaining. Then sympathetic nervous system activity now is an epiphenomenon. It is no longer the cause of the problem. It is epiphenomenon. You block it with beta blocker, do anything, the blood pressure persists actually, and beta blockers, of course, we otherwise also know the big issues. I wouldn't say that beta blockers are the way to block sympathetic nervous system. Ideally, it would be both alpha and beta. There are also drugs like labetalol or carvedilol haven't been very successful antihypertensive drugs. Or you have, of course, adrenergic neuron block, central adrenergic anti-adrenergic drugs, which are of course effective, but again they are modestly effective. They have never been very powerful. My own feeling is sympathetic nervous system plays a role in the initial part of hypertension. And that is why simplicity 1, 2, 3 failed.
Yeah.
They failed because you are now barking up the wrong tree. You should have done it when the patient was having more like white coat hypertension, more like labile hypertension, younger person with hyperkinetic circulatory state. They would respond better. And I asked Dr. Pati to comment on that.
Maybe only caveat remains with the high catecholamine turnover tumors, as Dr. Mishra has said rightly, pheochromocytomas. They are picked up and they are the very bad hypertension, and surgical response is very good in these patients of pheo. Then Cushing's and high catecholamine turnover tumors, you do the surgery, they respond very well. But for these two, other denervation therapy had hardly given us a good result. Agree 100% with Dr. Mishra's comment.
Thank you, Dr. Pati, Dr. Mishra, Dr. Sailja. I think time to wind it up. It is what, 1 hour and 40 minutes. 1 hour and 40 minutes. We keep it for actually 90 minutes always. After that, the attention span goes away and the back starts hurting. Of course, not for those who are actually lying down and listening, but to the faculty. So Amit, the floor is yours to say the final concluding remarks and let us close it. I, on my behalf and on behalf of our esteemed faculty, would like to express my gratitude to INTAS for continuing with this series. Although I don't think they have any direct motivation or direct motive to continue with this thing. And of course, I have to express my deep gratitude to this honorable faculty who have taken out time and participated in this very interesting, friendly, informal, free for all discussion on secondary hypertension and hypertension in stroke. Mr. Amit Arora, please.
Thank you, Professor J.C. Mohan, sir. As we come to the end of the third edition of Practice Pulse in Hypertension, on behalf of Zenith division of INTAS, I would like to thank all the viewers who joined in today. We had approximately 1,300 viewers and 1,500 registrations today from different parts of the country. And I'm sure today's webinar will contribute in some ways in better management of the hypertensive patients. I must thank you, sir, Professor J.C. Mohan, sir. You have been a guiding light in this program and you always keep on guiding us. I must thank Professor K.K. Tripathi for an excellent lecture and sharing his pearls of wisdom today. I must thank Professor P.N. Sailja. Despite her, other commitments, she joined today in the program, and I know how difficult it was for her today, and made such difficult subject of hypertension and acute stroke look so easy. And I thank today's panelists, Dr. R.N. Mehrotra from Hyderabad and Dr. Chandan Mishra from Kolkata, for sharing their views and making the program extremely lively. And I thank the support team at INTAS for doing excellent coordination. Please stay tuned in for next announcement on Practice Pulse on Hypertension for 4th edition in the month of October. At the outset, we look forward to your support for our antihypertensive medicines like Silni, and Silni M has been recently introduced, and Allmark in your patients of hypertension. So I must thank all of you for joining in today, and it's been a wonderful having you on this platform. Thank you very much to all of you, and good night to all of you. Good night.
Thank you.
Thank you.
Thanks
Thank
to
you.
all.
Thank
Thanks
you.
to the industry.
Thank you, ma'am. Thank you very much. Thanks a lot.